Good evening, ladies and gentlemen, colleagues and friends. Welcome to tonight's Sydney Prosthodontic Group CPD series. My name is Ben Lee, and I hope that you are staying safe and keeping well. Joining me tonight, of course, are my colleagues and friends, prosthodontist Dr. Johnson Chou.
Hi, everyone.
And Dr. Agnes Lai.
Hello.
Good to have you guys with us. As you guys know, that our webinar this evening is live and interactive. So what that means is that you can send us all your questions at any given time throughout this evening, and I will try my very best to direct your questions towards the panel for a discussion. Tonight's webinar is approximately an hour and a half long, and thereafter the CPD certificate will be sent out to you. Tonight's session, of course, is not possible without sponsorship by Credible. As you guys all know, that Sandy and Teresa, they've been in the dental industry for many, many years, serving us. So I would like to take this opportunity to thank them as well as the entire team at Credible for their incredible financial services over the years. For our referring dentists that are joining us again, I would like to take this opportunity that on behalf of the entire group at SPG, we would like to say a big thank you for your trust in us to treat your patients. Without your support, this simply cannot happen. And we do not take your referral and your trust in us lightly, because we know that a referral is often not just a simple letter. It often takes many, many different rounds of convincing. It's a process to get your patient to us, and for that, we are forever indebted. And for the audience that are joining us for the first time who may not know who we are, just a little bit about ourselves. Sydney Prosthodontic Group is based in Chatswood, Sydney, offering a full range of prosthodontic, restorative, and implant surgical services. Now, we pride ourselves on focusing not just on the patient treatment alone, but our mindset has always been on relationship building. Not only providing, obviously, with your patients with treatment to achieve their dental goals, but also to help you to overcome the endless clinical challenges that we all face every day. This year marks the 10th year for our in-house CPD series, where we have been given over 200 hours of free CPD over the years, sharing with our referring dentists what we have learned over the years as a result of treating your patients. So if you ever needed any help in any capacity, please do not hesitate to contact us, because with our collective resources, we are here to help you and your patients. That's enough about us. We'll move right on to tonight's topic of crown and bridge. As we all know that these procedures are very, very common, and but yet it still causes a lot of stress for many, many people out there. So I guess the aim of tonight's seminar is to share with you guys all the different tips and tricks we have up our sleeves throughout this topic, and hopefully to making clinical treatment just that little bit more predictable. On the topic of stresses, what in terms of crown and bridge, what gives you guys stress about this topic?
Oh, there could be stresses right, left, and center. So many different things that we'll go through our troubleshoot tonight. But if I must pick one, I'd say the control of gingival recession, because sometimes no matter how meticulous we are in screening the possible bile type and how far am I going to put this margin, how gentle or meticulous am I going to retract, what I'm going to use to minimize this outcome. And very, very thin bile type, and most often the highest smile line case is even just 0.5 or that much more recession is really unwanted. So if I have to pick one, I'd say that still somewhat falls in a little bit of unpredictable times.
Absolutely.
Yeah. What about you, Johnson?
For me, it's the color dissatisfaction at the trying appointment. Although by working with some of the best ceramists and with the new color selection protocol with a white balance card, which means they can measure the color very accurately. We can achieve color satisfaction in over 90% of the cases. But sometimes the ceramist can have a bad day, like any of us, and then got the color wrong, or the tooth just have so much character in it, or it's just very dark tooth that is very difficult to match to.
I guess we don't get the easy cases, do we?
No.
So it is an ambitious topic tonight, that under an hour and a half, and we have to cover all the different aspects of crown and bridge. So we have divided them into a few different subtopics, starting from post and cores, and then the actual preparation, the impression, provisionalization, and finally just a little bit on bridge design. So we'll go through these one aspects at a time, and of course, because of the time limitation that we have, we are somewhat skipping the treatment planning process. So and we really diving into these topics.
We've covered that before. So for those who haven't yet seen our previous webinar, they can hop onto our site.
Our website, yeah. So you can visit our website, sitpg.com.au, or just simply click on that logo, and that will bring us to our website. And then it's under the banner Dentist Resources to watch the previous webinars and a lot of other content that's there. So we are getting right onto the first section of crown and bridge. Before we're going to start just into the preparation, often you may have to construct some sort of post and core. Take this tooth here, for example. This was a molar that was root canal treated by our endodontic colleagues, and that was referred for a crown. And of course, after deconstruction, we can now see that there is a sufficient tooth structure to place a core where a post is not required. So simply by engaging some of the canal orifice, and in this particular case here, I decided to use a dual cure composite resin core after following the manufacturer's recommendation and partly using the orthodontic band as the matrix form. My ultimate aim after using this material is to carry out a crown preparation on the same day. So to make sure that it is fully cured, not all the material is dumped in one go. It is done in multiple layers. So unlike what the manufacturer is recommending, which is somewhat like 4 or 5 millimeters, because I am using an opaque material, which I like it because it's easier to see when you prep. You can see exactly what is tooth and what is the core material, especially when often we work subgingivally and with just bleeding and other bits and pieces, it's just really hard to see. So using an opaque material or a material of some other color sometimes it really helps.
Well, definitely, when there's low light environment, it's so much easier to pick up the difference.
Definitely. Okay. So these materials, so what I did was I used about 2 or 3 millimeters only, and then full 40 seconds of cure, and then another 2 or 3 millimeters. So it's almost like using as if I'm using a light cured only composite resin and hoping to achieve a full cure, before I can remove the metal band and then cure again from all the different angles to give me that reassurance that this core is well cured and ready to prep. And of course, the prep is reasonably straightforward, following all the parameters of retention and resistance, which we will cover next in our next little subtopic on crown preparation. But ultimately making sure that the final crown margin is beyond the restorative, the core margin. And then construct a pretty conventional PFM crown and lute it, and that's pretty much case done. Yeah. Speaking on cores, composite resin core is a very, very common material. What are some of the other core material that you might decide to use, Johnson?
Oh, for me, I mean, I like to, for supragingival cases, whether large, medium, or small, I like to use a light cure composite resin for the reason that they don't slump as much as a dual cure resin. So, and I do them in increments, so it's easier to shape. And for my final preparation, there will be minimal excess.
Right. So it's the control, the ability to shape that that restoration before the crown prep.
Yes.
Yeah. And how about you, Agnes? I mean, some of our viewers often may use something like a GIC or amalgam still. Yes. When would you use them? And any tips on using that?
I think it's well covered between yourself and Johnson already about the use of composite resin. In terms of use of glass ionomer, if the involved area is relatively small and well supported, and sometimes if there is enough ferrule and that this particular crown will only be receiving much compressive loading, not too much lateral flexural forces, then I'm quite comfortable actually using GIC for small to up to medium area size. In terms of amalgam, yes, there are times where I'm very comfortable with amalgam core, especially where I have used it to place an amalgam crown for maybe a number of years, may or may not actually transition to a crown. However, I've rarely used an amalgam as a core material if I'm going to prepare the tooth on the same day. Usually it would require a revisit. So I guess that's the main difference.
Definitely. So ladies and gentlemen, please do send out your questions to us throughout the evening. As this session is live and interactive, we are here to answer any questions that you might have, any problems that you may face during these crown and bridge procedures. Moving on into some posts. Now there are some teeth sometimes that needs a little bit more than just a direct core. Now Johnson, I believe you have a case which you have, I believe, used say a post. Now we all know that of course post, there's many different type of posts out there. There's these metal stainless steel posts like para posts, which everyone knows. There's composite resin reinforced posts, which are becoming very common, and a zirconia post. So a lot of different direct posts out there, and we'll come back to cast post and core as a separate little add-on. How do you go about selecting the right post, what material to use, and why do you, for example, use certain type of posts that you like to use?
Yep. So for this case, the patient received Emax crowns while she was overseas 3 years ago. The splinter Emax crowns had failed because first the margin was subgingival. I mean, for some reason they were splintered, so there were differential movement. But most importantly, the core, there was not a lot of core material or tooth structure remaining. The teeth were over prepped and then over tapered, providing inadequate retention and resistance form. So if I was going to redo the Emax crowns, it would definitely fracture or deboned.
Yes.
Yeah.
Right.
What made this case challenging was the teeth were electively endodontically treated as well for some reason. So when I removed the amalgam core, another strange reason is they placed amalgam core for the anterior teeth for some reason. There were insufficient ferrule thickness at the buccal and the palatal aspects. If I just build up the core, the bending movement would have an increased risk of a coronal root fracture.
Sure.
Or tooth or root fracture in this case. So I have to select a appropriate pause for this case. There's the parallel pause, which require more tooth structure removal because the canal gets more narrow towards the end.
And the shape of these posts are quite parallel, isn't it?
Parallel,
so you do have to remove more apical tooth structure.
And the fiber post is more tapered. Less tooth structure removal is required, but then you still do have to go through the selected post for the fiber post to fit. Very minimal preparation by hand. Yeah. And traditionally, that we always require 5 millimeters apical seal. And when I first started doing this fiber post, I always do follow to that principle to maximize the retention.
Sure.
Yep. And this is another picture showing that if we were going to do the prefabricated stainless steel post, it would be a little bit too aggressive for the lateral incisor.
Sure.
I mean, alternatively is you can use a small loose fitting stainless steel post.
But it will be quite loose, wouldn't it?
Quite loose, and then you do have quite a bit of a cement space. But nowadays, with a dual cure resin cement, the recommended depth for the pores is 6 millimeters. The advantage, you don't have to drill deeper with the increased risk of perforation.
Absolutely.
And then, or if you drill the pore space deeper, I mean, although you maximize the retention, but there's always an increased risk of root fracture.
Sure.
Not so much for the fiber pores, but with stainless steel pores. Yep. And then once I build up the core to provide the retention and resistance form for the future crowns, porcelain fused to zirconia crowns were cemented. And I've got a 2 years follow-up for this case.
Beautiful case. What about zirconia post? Would you consider using that?
Zirconia, I mean, is very rigid material. The issue is there's increased risk of a root fracture, but should the pores fracture as well when it's cementing with a dual kill resin, you just can't retrieve it, or very difficult.
Absolutely.
Yeah.
I think it's certainly an endodont's nightmare, isn't it, when a zirconia post that breaks?
Yeah, definitely.
One question from the audience asked was which dual kill material do we use? The ones that you saw on screen earlier, that white opaque material, it is by DMG. It's a Luxor core. It's another disclaimer is that we do drop a lot of names, a lot of brands, a lot of material this evening. We do not have any affiliation or a conflict of interest of any of these materials. These are just purely by personal choice, something that works well in our hands, and that either something that we believe in or something that we just find or that we just used to. So what about cast post in core, Agnes? When would you consider using that?
Okay. So thank you, Johnson, for covering all the prefabricated posts. When we move to discussion with cast post core, the major difference really is that the post and the core is of one piece. And when it is cast in metal, it's also the most rigid form. Now, traditionally, it is utilized mainly in the anterior region, where a tooth may be expecting to have much lateral forces on it. So the concept is not too different from prefabricated posts, where we could achieve is we want to have maximum fit of the post structure against the root, internal root structure, so that it could maximize any bending movement and resist those flexural bend. And in saying that, we want to minimize the cement space. So typically the type of scenario nowadays with such handiness of the prefabricated and tapered posts would be in central incisors or canine areas where the root configuration is a little bit more ovoid or convoluted of two canals, whereby even in a pre-tapered fiber post, it may not be the most well-fitting, and therefore you may expect a lot of resin cement. Now, having said that, there are now also fiber reinforced material that allows us to dip and form a single cast post core in fiber resin, such as Everstick. So it utilizes that same concept. But I think in the end of the day, we can agree that our post choice, no matter if it's prefabricated or cast post core, the main message here is that the two main functions of utilizing a post is, one, that we all know and agree, is we need something to help anchor our core material. But two, most importantly, I just want to highlight what Johnson had said, is that it helps to minimize any need for further reducing or sacrificing our ferrule width or height. We really want to preserve the tooth structure. So whichever modality we end up choosing, the whole aim is to minimize the root preparation to achieve the anchorage of the core material, as well as to actually improve or reduce any risk of root fracture.
Yeah, absolutely. As in the tooth is already structurally compromised enough as it is. That's why you need a post. And let's not compromise the root system any further.
And not that we're saying the post could actually strengthen the tooth in any way, but it does reinforce an otherwise compromised tooth
Sure.
to reduce its chances of having fracture risk down the track if we are actually designing appropriately and further sort of warranted if there's good Ferrule, which is very important, and we'll be highlighting it.
Absolutely.
Yeah.
There's one question from the audience, which is, if you were to choose to use an amalgam core and then subsequently restore it using a full gold crown, is there any concerns of any galvanic reaction between the metals used?
Not with my experience. Yeah, I haven't had any cases with the galvanic issues.
Yeah, I mean, amalgam core and full gold crowns, I think it's been used for decades. You know, there's a bit of a historical, I think, sort of, no, I shouldn't say historical dentistry, but it was once upon a time very, very, very popular. It's slightly dying out of fashion these days because of the aesthetic world that we live in. But I think there's, with a lot of units out there, I think if there's a big problem with that, I think we should have seen a lot of problems with that by now. So that's certainly not that commonly seen in clinical practice. Now, assuming the tooth now has a sufficient post or core, is ready to be prepared, one of the things that just before we started with the crown preparation is actually the insertion of the first chord, because a lot of the cases that's sent to us to treat, there's probably not a lot of tooth structure there, or sometimes it's very heavily discolored. It's certainly not a tooth that with an abundance of tooth structure. Those ones don't come to a prosthodontist. So very often I find the first thing I have to do is to insert a first chord. And the point of that is to apicalize the gingival margin. So as you guys can see on screen, this is like a before and after insertion. And what you find is that the two teeth that the 000 chord is inserted with the red arrow shown, as you can see that the gingival tissues are being apicalized. And that is to, of course, so now you have more tooth structure to prepare so that you are apicalizing your crown margin into the intrasulcular space. And that way that helps you to hide that transition between your crown and the tooth, and making your teeth more recession proof, so to speak, and also gives you a little bit more tooth structure to prepare to obtain that ferrule, improve your retention and resistance. So here we have a video, I believe, showing the insertion of this first chord. Any particular chord size that you guys tend to use?
My go-to for the first chord is 000 often the times, because I want to choose the smallest sort of unimpinging type of chord as my first chord placement. And I think it's very important to highlight that even though when you refer to the purpose of the chord being apicalizing the soft tissue, note on the video here, one of the very important tips is that the purpose of the chord, as Ben carefully tucks it in, he does not just apply a vertical pressure and press this chord into the sulcus space apically. What he does is that he actually rolls the chord and apply a lateral tucking forces. What we want to do is lateralize these gingiva. And that is how we respect this sulcular space to prevent any sort of trauma to the side or prevent gingival recession. Yeah.
Any clinical tips that you could share with us, Johnson, about inserting chords?
Yeah, when inserting chord, I like to start from the buccal aspect, and then from the interproximal, from mesial buccal or distal buccal, depending on the quadrant. So basically, the area is easy to start picking your chord into, and then I'll pick around. So at the end, when I trim the chord, it's much easier to trim, but also when I remove it, it's easier to remove as well from the buccal aspect.
So you always start from, say the mid buccal or something like that, and you just go once around the tooth. It's just easier to start, easier to finish.
Yes.
Yeah, each and every time. Yeah, no, that's a great tip. Would you guys use any hemostatic agents during this process?
Always.
Yeah. Any particular material that you like to use?
I like to use visco stat clear because I find the visco stat that you get quite a little bit of a coagulants and a lot less with visco stat clear.
Definitely.
Yeah. And also visco stat clear show you need retraction cord just to control moisture or bleeding, that it doesn't affect your bonding or the color of the bonding.
Absolutely.
Yeah.
Now, I should probably say just to do a little like a little brief intro about this particular case. This is the case. It's a bridge case, which I'm actually replacing an old 5-unit bridge. This was a case that was recorded for the ADA New South Wales. So just in case you were wondering why the preps look like this, why does the teeth look like this, this was after when a pre-existing bridge was removed, and I just have to pick up where the previous clinician left off. So assuming that the first chord is in and we are ready to carry out a crown preparation. As we can see in this video, we are starting prepping from the buccal aspect. Any tips that you guys have on prepping, Johnson?
Yeah, for me, I always like focus all the attention on the buccal aspect. You need to provide the right thickness for the ceramics to give you the very nice final outcome.
Yes.
And plus, you know, when the tooth is either buccally placed, you do need to take a little bit more, or when it's palatal placed, you take your reduction is a little bit less because you have the space already. And once I have the buccal prepared, they will guide my preparation for the palatal to ensure they are absolutely parallel.
Yeah,
to,
always use the buccal as the reference point.
A reference point.
Yeah,
yes.
Absolutely. Especially a lot of the aesthetic cases that you do, it's so critical to achieve that.
Yes.
How about you, Agnes? Any clinical tips that you could share with us?
I like to take a longer sweep movement when I do my crown preparation. A little bit more like perhaps like a sculpting or icing the cake kind of. And I take a lot of visual references to neighboring teeth or look down the buccal corridor in terms of the amount of reduction that I may require. But essentially, I find taking the longer sweep type of movement on a high-speed handpiece, full blast, you don't get too much tactile from it, but the whole idea is actually not to have any pressure, digit pressure against your prep. You just essentially like stroking the cat, wanting like that ice skating surface smooth type of result. And if you do very small movement, I find that it tends to leave a very jagged type of surface as you go, which then you have to go over and smooth again. So that's just my personal preference.
Sure.
Yeah. I think everyone has to find a way that works for them. Some people are more visual, some people are more tactile. So it's a nice night to be able to sharing different techniques.
Definitely.
Yeah.
Any tips on polishing, Johnson? We know there's so many different ways of polishing. Any particular burr, any particular instruments that you like?
Yeah, I like to go with my high speed at a slower rate, so more tactile sensation. But I also like to use a finer grit, so the red band or the yellow band to finish with irrigation. Yeah.
Okay. Agnes?
I do find that a lot of times when I use the technique I described with a red band on a high-speed handpiece, there's very little finishing that is really required. However, there are times, especially on vital preparation of teeth, where I may have some concern of post-operative sensitivity. Sometimes I do use the multi-fluted carbide to do a smooth polishing, which can then help produce a smear layer to block those dentin tubules, but selected cases.
Absolutely.
Yeah. How do you polish your?
Well, as you guys can see on the video just then, my go-to technique is that when I've already finished my gross reduction, I just want to polish my final margin. I actually prefer to use a high-speed handpiece, but at a very, very low rev, using a polishing diamond like a red band, something a yellow band, and just to run around the margin very, very, very carefully. So during the recording session, everything is magnified. Everything just looks like there's a lot of perhaps a lot of tooth still reduction at the margin, but actually, clinically, there's actually very, very little. So, my diamond never touches the long axial wall because I don't want to overheat the tooth, the pulp. So I'm actually just touching at the margin because I want to visually see that it's nice and smooth. So instead of Agnes going fast and furious, I tend to go slightly slow and steady.
You win the race.
To the audience, yes, this session is recorded and it will be made available on the website to view on demand at a later stage. One other question that's asked is, any tips on preparing multiple units at the same visit? It is a little bit of an open-ended question, so there could be anything there.
Oh, there are so many tips along the way that we've covered already. But for multi-units, I try not to do the chord placement right up to each other, because then you can put, especially the second chord, because you could potentially affect the coal of the papilla.
Yeah, the coal is the soft tissue, the attached gingiva.
That's right. And in terms of, I suppose if you're doing multi-unit preferences, I would also use, for the crown preparation, I'm jumping here and there because I'm answering your live questions, but for tooth preparation, I would actually like to use photographic mirrors. So like, a buccal or occlusal mirror, which then gave me that bird's eye view of, between the two crown preps. It's much better than trying to move just one little small mouth mirror across from
the audience may have seen that towards the end of the video. So, I mean, my concept of using that large mirror was actually to check the parallelism of some of the abutments. So I find that one big mirror is much easier than using a smaller mirror. You got to move between teeth to teeth.
Yeah, definitely. And it's very helpful. Yeah.
Now, there's, of course, a lot of challenges between preparing an anterior tooth and a posterior tooth. They all have their own unique differences. Now, for an anterior tooth, it's because of visibility is usually not a problem. So quite often it is easier to achieve reasonable parallelness in terms of the mesial and the distal walls. And we all know that your ideal taper should be around about that 10 to 20 degrees of total occlusal convergence to give you that reasonable retention form. But one aspect that I find often quite challenging to achieve for an anterior tooth is that parallelness buccal palatally. And the reason for that is because a lot of the clinical teeth that's presented to us, it's not like what you see in this picture, where the buccal and palatal walls are reasonably parallel and that central incisor has a reasonably long cingulum, which all you have to do, if you were to prepare this tooth here, is just to follow its natural anatomical contour, and that should be fine. But a lot of the teeth that you have, it's look like this, in the picture in the middle, where the cingulum is a lot more tapered. So if you were to follow the natural anatomical contour, which is not parallel between the buccal and the palatal, before you started, you've already lost pretty much most of the retention and the resistance form. So that's why for these particular teeth, you do have to angulate your palatal burr in the same plane as your buccal wall to keep that as that taper not over tapered. And when you carry out your palatal reduction, it's also extremely important not to touch that region that's indicated by the yellow arrow, because now that you've worked so hard to achieve that parallel wall, let's not get rid of it like what's shown in the picture to the right. So that's not the right thing to do. Now, when you do that, what that essentially means is that you may have underprepared that region highlighted by the yellow arrow, right? Because you haven't really prepared that. And what that then means is that your final crown needs to be built up a little bit larger than the actual cingulum, and your new contour is bigger than the original tooth at that cingulum point indicated by the yellow dotted line. So, but not in every clinical case you can do that. There's a lot of situations where, say, for example, your patient may be, say, class 2 div 1 with a deep bite where their mandibular incisor is digging right up into the cingulum of the upper tooth, so there's no clearance for that, or sometimes maybe for phonetic reasons. Some patients just simply cannot tolerate a larger contoured palatal hump, so therefore you have no choice sometimes to cut to reduce the tooth in its normal manner, meaning that you are losing or sacrificing the retention resistance from that palatal shelf. And in cases like that, then I would recommend, wherever possible, to introduce some grooves. Typically, the burr that we use here is a 06, fine diamond, and your angulation is parallel to the buccal wall, and I would place one in the mesial and one in the distal, about half burr depth into the two teeth. And once you've done that, then when you view this from the incisal aspect, and what you can see is that there's roughly 3 planes or 3 walls that's somewhat parallel to each other: the buccal, the mesial, and the distal, where the palatal is not offering a heck of a lot. So I find that technique can help us to overcome that clinical challenge from time to time. Now, for posterior teeth, that they have their own unique challenges, don't they, Agnes?
Yeah, so I think, it's almost like a repeat retention resistance form continue to be a challenge, especially when after any occlusal reduction, often the clinical crown height will be significantly reduced. And as you refer to the total convergence angle that Ben has spoken about before, if you are a very skilled operator where you're doing only 5 to 10 degree taper, then the minimal crown height that you have to offer good resistance retention form is 3 millimeters. But if you're a general operator where your total convergence angle is more towards 16 to 20 degree, then you really need about a good 5 to 6 millimeter of clinical crown height, which we rarely have. And if you now refer to the photos here on the slide, there are 2 main troubleshoot areas that often I get asked, or in our discussion, that clinicians find stressful and heart pumping. Now, one of them is to be cutting through the distal contact. Let's, for example, in this scenario, let's take an upper 7. Cutting through that distal contact where the contact point is so tight and they feel like life is on a thin line. And the second troubleshoot is the tendency to taper in the prep, especially on the distal palatal corner. So I hope the above a few little tips you can carry away with you the next time you have a upper molar prep that you can do. So if we were to see the next slide here, so for those who think life is on a thin line, no. Because when in molar crown preparation, you got to remember we want to maximize the clinical crown height. So many a times, trust yourself, your marginal depth actually have to be at least 0.5 subgingival, if not further down. And if you are operating at this marginal location, then keep the orientation of your burr along this path of insertion at where you see it, at this apical level. Because if you then start to section through that distal contact at this point, rather than going very close to the contact area, you find that you're quite a safe distance away from your neighboring tooth. Most people, they can work on a direct fission as they are sectioning through this contact from a buccal aspect, going towards distally. But what they then do is that they will then have to look at the indirect vision, utilizing their mirror as they continue to section this contact. We'll speak about the beautiful grooves that Dr. Lee have put here, about additional retention form later. But what I'd like to illustrate is see how he's really maintained, a very minimal taper in his preparation. And the reason why I would like you guys to consider why, if you happen to be the type of operator that tends to taper in your prep at this distal palatal corner, perhaps this is the reason why. As you look at the slide right now, this would be similar to the indirect vision that you see on your mirror. And as you continue to section through towards the palatal with the blue arrow and pull towards the mesial, which is directing your burr now, if you're sitting at 12 o'clock at the patient, you'll be pulling your burr now towards the center of your core. And as you do that, it is very easy to also move your wrist. And without knowing, because you're actually looking through your indirect vision, it is so easy to taper unconsciously because that is your ergonomics. So what you would in fact do is, as you are continuing to section through this distal contact, look at your neighboring tooth and just follow the contour as you exit. Because as you're looking at that tooth, you're not going to cut into that tooth. And as you are now sectioning through the contact and moving it distally along the arch and away from your body, you are in no way of tapering your core anymore. Once this contact is sectioned through, you will find that it is a lot easier to continue the rest of the preparation relatively stress-free, because now you've maintained that path of insertion.
Yeah, in the worst case scenario, you can have a little bit of underhang or undercut, sorry, beg your pardon, and that's always easy to polish.
Yeah.
But once you have too much taper, then that's sometimes much harder to get yourself out of that trouble.
Yeah, and that's on the proviso that the tip of your burr is at your marginal location, so you're not like actually, grossly cutting into the tooth. But hopefully, as I say, everyone works different ways. So, but perhaps this particular presentation of some perspective and how it relates to your movement as you work can help you troubleshoot for yourself the next time you visit your own crown preparation.
One question from the audience asks, how much resin cement can compensate for a short crown preparation?
I think that's the golden question. I think if you are relying on resin cement and majority on your dentine, we know that the bonding actually go under dissolution over a period of 5 to 6 years. So if you're actually just totally relying on dentine bonding, then it's not going to last very long. Especially where if this particular crown is challenged again by severe bruxa, a lot of kind of shear flexural jiggling kind of movement, it will go through that degradation much faster.
Definitely. Yeah, so wherever possible, I think in prosthodontics we aim for much more mechanical-based retention and resistance form. And if you can't achieve it, well, maybe perhaps that tooth should not receive a crown sometimes. If you just simply, for whatever reason, you just cannot achieve it, maybe not decide to crown that tooth, or you got to do something else to increase your clinical crown height. That could mean crown lengthening surgery. That could mean your orthodontic extrusion. First, you get more tooth structure so that you can carry out the adequate crown preparation.
Yeah, so for single units to resist that, buccolingual type movement, you can see that the grooves are commonly placed on the mesial and distal aspect. But if it was on a bridge scenario, sometimes on top of that, we have to consider placing grooves on the buccal and lingual palatal aspect to resist the movement from a long span, which again, we will touch up on this concept later when we talk about bridge designs.
Absolutely. Yeah. And just another quick question before we move on to the next topic. Do you guys ever use Teflon, PTFE tape? I guess this is, you twist it, make a little twist, and then you use that as your first chord. Routinely for your crown prep.
Yeah, I've seen it. I probably wouldn't really. I haven't used. I cannot say I've used it myself as a first chord.
And I think I'll add to that the reason why. The reason why is because the first chord, the point of the first chord is usually, it's not to say provide that much tissue retraction. It's not usually for your impression purposes, which is usually done, carried out by the second chord. It's really just to apicalize your margin. And the other thing is that a lot of the teeth that we work with, for example, especially say your lower canines and lower premolars, where your buccal sulcus is so thin, even just to try to get a 000 chord in there, sometimes it's hard. There are cases that actually I open a packet of black silk suture, cut the black silk into small sections to use the black silk as my first chord. So it just, in those sort of cases, as a routine go-to material, That's why I haven't found a need for that material.
And I think it's, I have tried it and I have used it sometimes to fill thocular space that is very mobile at times. But I think for the audience out there who do use the PTFE, you may agree with me, there are different thickness, and also even when you roll it up, it becomes different rigidity almost. And the way you then insert that into the sulcus space, there's a lot of trial and play to the individual operator, but I would just key in the same concept is you do not want to trauma the soft tissue as you're inserting. So if you roll up very thick or very tight of this PTFE and end up having to actually apically push it into the sulcus, then there's a lot of room for error in terms of the soft tissue response to that. So, but when used well and respectfully, anything that fills that space and given time will allow you to you know, visualize that space or capture it in the impression, and there's no doubt.
Yeah, thanks so much for all the questions, guys. We've been overwhelmed by a lot of questions, which is great. So it's unfortunately at this very moment we cannot answer all the questions that are there. But rest assured, you know, we are more than happy to stay behind, so to speak, and to follow up with any questions after the 1.5 hour session that we have. So please keep all your questions coming. One question from the audience also asked, you know, how much retention do we need? So this is a good video to showcase that. So when you invert the model upside down, typically you will give it a good tap. What you want to see is that the crown shouldn't immediately fall off, and yet it should fall off towards the end. And what that means is that there is some friction, obviously, between your crown and the tooth. The fact that it is falling off, rather it's not falling off, meaning that the crown has been engaged and undercut. So that's sort of the ideal.
Another way, if you don't want to risk losing your crown or falling off, is that I would commonly just you know, not let the gravity challenge it, but I will apply digital pressure at either the incisal edge or a cusp tip and mimic that buccal-palatal movement and see if I can actually rotate this crown off. It really just check in the resistance form, not so much the retention, but often one will go together with the other. So that could be another way too.
There's a lot of questions on Ferrule, so I'm glad about those questions. So let's talk about Ferrule. Ferrule, as we all know, is that little lip of tooth structure, the natural tooth structure that your crown has to grab hold of. There are now a few studies that looking at, do you need circumferential Ferrule? And the answer is yes. You know, so often in clinical dentistry that we probably have enough buccal and palatal or buccal lingual Ferrule, but often it's the mesial and the distal sections where it's really challenged. You know, a lot of the teeth that we work on may already have a very deep, you know, like a MOD or DO restorations or something like that because of caries often. And so those are the points that you think, oh, well, you know, I got half of the tooth, I got ample Ferrule, but it's the mesial and distal that I practically don't have any Ferrule, but I still got some Ferrule there. So, you know, clinically it may make you feel okay, but these laboratory studies have shown that in those cases, there's a significant increased risk of having, you know, catastrophic coronal fracture once you crown those teeth. So just bear in mind that we ideally want a circumferential Ferrule of you know, minimum 1.5 millimeters of tooth all the way around, which is a lot to ask in a lot of the cases that we treat. So take this clinical case here, for example. It's a young lady who broke her central incisor. The tooth is already root canal endodontically treated. She is very young, so biologically, you know, she's not ready for an implant replacement. That's using the ideal age as a parameter, and emotionally, she is just not quite there yet. So she really would like us to quote unquote save this tooth for now, for as long as possible. Essentially, is to buy time until she's biologically and emotionally ready to depart from this tooth and for an implant replacement. So with that in mind, here I've placed a fiber reinforced composite post and a core. So while I have adequate retention and resistance form with my prep, but so far there's absolute zero ferrule at the moment. So personally, I don't feel comfortable in making a crown to put it on, because that post is not that strong. It's just asking for a fracture in my personal opinion. So and like I said earlier, your options to achieve more ferrule could be crown lengthening, could be orthodontic extrusion. Here for an anterior case, I just cannot carry out crown lengthening because your gingival level just cannot have one tooth that's taller than the other. Aesthetically, it's simply not acceptable. And she declined the option of orthodontic extrusion, which I think is a brilliant idea. But for some reason in the real world, patients just really tend to resist that option. So I had no choice but to go subgingival. As you can see in the clinical photo, there's that color difference, whereas you got that yellow color, which is completely under the soft tissue. So I did have to invade the biologic width, preparing fairly close to the bone level to achieve that 2 to 3 millimeters of ferrule all the way around. And that's the only way to obtain a result that satisfies all the other criteria that we spoke of, adequate retention, resistance form, and ferrule effect, circumferential ferrule effect. Despite invading the biologic width, as you can see that the soft tissue is still nice and pink.
And look at the stippling that you can see here.
Yeah, it
responded really well.
It did, and we're very lucky that she had a thick gingival biotype, and of course it is a technical excellence sort of exercise, and also have the tremendous laboratory support. They can make restorations like that for us. So moving on to the next topic of impression, we all know the importance of capturing a good crown or bridge preparation for our technician to construct the crown. We all know that our impression should be bubbleless and defect free, free from no drag marks. It's a good, accurate representation of the crown preparation. Apart from all those wonderful things, what are some of the other aspects of the impression that you might be looking for, Johnson?
Of course, you need a very well defined margin, but on top of that, you need a color of impression material into that circular space. And you need to be able to get that color of impression into the circular space. We need a bigger second retraction core we will go into a little bit later. And what that means is on the master model, that you will have a well-defined margin, but very importantly, you have that circular space indicated by the yellow arrow. Because ultimately, before the technician can make an indirect restoration for you, they need to trim the die or the master model or the die in that case. And it is in our best interest to make their job very easy.
Of course.
By getting a very well-defined margin, and secondly, for them to trim that die very easily. So the thicker of that collar created by expansion of the circular space, the better. Because if we don't do that, then they may damage the model, or damage your margin, and they have to guess where your margin ends.
Absolutely.
Yeah.
Yeah. No, very true.
Yeah, and I think sometimes capturing that circular space and to actually see how the root emergence go towards your margin is also very helpful for the development of emergence in your prosthesis, whether this is your crown, how it emerged to the proximal contact, or on the labial area, how it developed to the center with the the cervical bulb and so forth.
Absolutely.
I think it's only until we have to trim our own dies during our training
we
that
appreciate.
we really appreciate trimming under microscope. We need minimum 0.5 millimeters of that impression color to.
That's very true. Historically, my impression, I remember that little lip of impression material. Historically, it was quite thin.
Yes.
It was until that we had to trim our own die, and then we realized, oh, this is really hard.
Yeah.
It's so easy to damage your working die.
Yes.
So, and when you have a thick collar, well, there's no way your burr can touch it, and it just looks so perfect. So yeah, that makes you appreciate how important that expanding that gingival tissue is using that second chord.
Definitely.
So looking at this case here, these two teeth have been finished prepped, and they are pretty much ready to take your impression. And when you view it from the incisal aspect, you can only see, of course, there's just one layer of the 000 chord in there. And if you were to take an impression now, although we, as the audience, we can see perhaps where the crown margin ends and when the soft tissue begins, but when you translate that into a model, there is no color difference anymore. It's just one uniform blob. So it's almost impossible for your technician to know where your crown margin is. So then they have to guess and etc. So that's why it's so important to insert the second chord. And so here's we have a video of us inserting the second chord. Any particular things that you may watch out for during this stage, Johnson? Because you have a very good tip about looking at bleeding, isn't it?
Yeah. I mean, for me, once ultimately after I insert the second chord, I want to be able to visualize all the tooth, but also ensure there's no bleeding as well on the gingiva.
Yeah.
So that can be done either ensure the tissue health is optimal before we start, but also very importantly, asking patient to stop anticoagulants 3 days. Subject to permission of the cardiologist, of course, or the medical practitioner. But also there are natural anticoagulants, for example, vitamin E, fish oil, and also herbal medicine. We ask people to stop. But should they stop all the medication and the gingiva is still bleeding, then I just put a couple drops of local anesthetics containing adrenaline to stop that bleeding.
Yeah.
Because if I don't stop the bleeding right now, it's often when I remove the retraction cord, there can be a bit of a seepage of blood.
Definitely.
Yeah.
I see. Yeah, sometimes I find if it is not on my first encounter that I'm doing this crown preparation, often there is time to instruct our patient to have meticulous oral hygiene, and perhaps the 3 to 5 days leading into the crown prep appointment where we do plan to place a subgingival margin and impression, just ask them to go on a chlorhexidine mouthwash twice a day.
Pixis dip in Savical. I find that works really well.
Yeah. So I think nothing beats working with a very healthy gingiva. Yeah.
And Agnes, how many layers of the second chord do you use? Because a lot of people say, I've used my second chord, but it's still not working. Why is that?
It's interesting. Over the years, I've tried different things, and what I like to do now, and it's a good point, we actually have not mentioned it, is once upon a time, I used to think that and I still to a certain extent do when I teach basic dentistry, to relate the different size of the chord to a particular expectation of how much you would retract the gingiva. So, but a little bit of an extension here, as we all know as clinician, is that depending on the tissue type, and that could even vary itself circumferentially around your preparation and have different sulcular space. And then so nowadays, my go-to is I get a very long size 0 chord, and I will go around, and where areas I expect a little bit more mobile tissue, I might go back and forth a couple of times before I continue this circle. And the whole idea is that within the one chord, I actually fill this sulcular space. Because the whole point is practicality and making things easy. So after I wait the long 5-6 minutes, and I'm so impatient. I have to keep myself occupied with something else. Otherwise, I'm staring at this, then that 5 minute gets longer.
5 minutes is short. I usually wait like 10 or 15.
No, at least
I wait 15.
at least 5 to 6 minutes. But then when you go to remove this chord, you just want to remove it in one go, predictably, instead of digging around and risking for a thing. Yeah.
But I guess the point at the end of the day is that when you finish inserting your second chord, and when you view that tooth from the occlusal or the incisal level, is that you want to see full tissue displacement, as in you don't want to see the tissue still in, rolling over your crown margin. That's the ultimate aims, and it doesn't matter how many layers you need. You got to achieve that.
That's right.
It is irrelevant saying whether I put 1 or 2 or 3, because if you haven't done that enough, well, your impression, your tissue hasn't been displaced enough, which means your impression material is just not going to get into the sulcus space at the end of the day. Instrumentation. Any particular preferences on instrument, cord, packer?
Yeah, but I tend to find like, instruments, they come in serrated and sometimes they can tear your cord or have a bit more trauma. So I think in your practice, I mean, you basically flatten, customize all the cord packer for all of us to use to reduce the trauma and then to reduce the restriction cord from coming back.
Yeah, so a lot of the cord packers, they when you purchase them, they come serrated with these little teeth on them. So it's just a personal preference that I find when you have a little teeth and you try to push or roll, it tends to sometimes when you back out, it tends to pull your retraction cord out. So that's why I've used my diamonds. I actually cut away the serrated strip, the teeth, and then highly polished them using browning. So I actually made it's like a customized cord packer. I just don't find those things around. Okay, so now that we've got the second cord in place and we waited very patiently, as Agnes said, for long enough, I mean, you don't have to just stare at it. There's plenty of other clinical things to do, right? You can take an alginate of the opposing teeth, you can take an MMR, you can write your lab sheets, clinical notes, surf DPR, and join in the discussion.
Cup of tea.
Yeah, that's it. And then, of course, you'll remove your second cord. And so when you do remove the second cord, it should look, your teeth should look something like this. Well, you should be able to see that sulcus space, and now you've got ample time to start working it and taking your impression. So here we have a video of impression taking for this 6-unit bridge. So what you see is that I'm actually blowing air, and the reason why I do that is because the impression material that we use, they're reasonably hydrophobic these days. And again, we're going to go into a little bit more detail on the impression material in just a moment, and I want to dry the soft tissue, the prep that we try to capture now before I take out the second cord, because if I took out the second cord and then I dry it, blow air, sometimes your first cord comes out, and when the first cord comes out, and that's when you get bleeding. So that's why I find it's really important to apply air now. And following Johnson's advice on placing your cord always consistently from the buccal aspect, so you can see for multiple units now it's just a little bit easier to remove your second cord. Johnson, you have a tip in terms of you injecting light body around the tooth. Could you share with us?
So I mean, when I inject light body, I would like to have it as close to the tooth as possible. But it's when you get to the interproximal area, it's going to squeeze a bit harder, hoping that hydrostatic force would try to improve the adaptation, especially when I have blow the first light body, and then when I go for the second light body second time around. Yeah.
Agnes, any particular tips that you have, particularly when you're working multi-units?
If you really require a bit more working time, it's not recommended by a manufacturer, but but it is polymer and monomer sort of like polymerization reaction. So you can actually chill your light body and heavy body. Make sure you chill both. You can chill it to stay chill yourself, and then you just have to then allow for more working time as well as more setting time. So don't remove that impression too early, but then certainly you can have a little bit more comfort in knowing that you have that little bit more time at hands. Yeah,
absolutely. Any particular material that you guys like to use when taking impressions?
I still like the light body, heavy body,
light and heavy combo
for the tooth bone prosthesis.
One question asked, do you really wait 15 minutes before removing the second cord? Yeah. I mean, especially a lot of the cases, as I said earlier, prosthodontists don't get these straightforward cases. I don't think I ever did a crown in the last 5-10 years where I don't have to go subgingival. And because of the fact that we have to go subgingival, that's why the second cord is there for stop bleeding, provide ample soft tissue retraction, and it takes time for that for that bleeding to stop. So that's why, we have to sometimes wait that long.
Yeah, I think for the audience, you can develop an ability to assess the sulcular space, the vulnerability of the sulcus to then, or the sulcus doesn't collapse, but the gums, the vulnerability of the gingival margin to collapse back into that space. And then with your own experience, you can then assess how much time you may leave. But I think quite safely, between 6 to 15, maybe say at least 8 to 10 minutes is a good go-to if you don't want to keep taking out this cord, check, it's not ready, and then you have to spend time to repack the cord. Then sometimes a few minutes actually wins the race.
So maybe for if it is equigingival, I mean, this is when I used to be a general dentist, then a couple of minutes is sufficient.
Probably
1 millimeter, 5-6 minutes.
And if you're doing, say, 1 unit, or
one unit,
like that,
yes.
But
probably. I think 2 or 3 millimeters. I think 10 to 15 would be
And certainly
guide.
For supragingival margin, you don't need to necessarily put second cord either.
Exactly.
The whole idea is to be able to visualize not only your margin, but at least maybe comfortably 1 to 2 millimeter at the very minimum beyond your margin. Is what we're referring to. Yes.
And of course, this is the impression that we've taken with that particular case. This is the one-step technique that we have covered. There's also, of course, the two-step technique, which I know that you're very fond of, Agnes. Could you go through with that? What is it about?
Such difficult case obtaining one-step technique. No.
That's what it is, and in what situation do you use that?
Okay, so with the one-step technique, is that you are basically relying on your light body's material affinity to spread itself and capture the detail, the fine detail of the margin, or flow itself into the sulcular space. And Ben will cover how it flows itself, or you blow air into later. But when situations that does not allow you to do that, such as fairly deep subgingival area, difficulty in moisture control, parameters that you just don't want to jeopardize doing things multiple times, then you may choose the two-step technique, whereby you aim to capture the detail by moving this light body material into the details that you want under pressure. So what you can see here are the differences in what you can achieve within a two-step technique. And what you would do is that you first form an ultra customized tray with your heavy body material. Now, depending on what school of thought you're from, some might have taught this technique by using a putty with some glad wrap, and that you take an impression of the arch. You don't even have to wait for it to set inside the mouth. You can then take it out. But quite conveniently now, I would just do this, in my tray. I actually let it set in the mouth. I then remove it, and I would then cut away all the interproximal areas. So I actually now don't want the major details, but I want it to also be easily repositioned and reseat into the arch. Subsequent to that, because we are using pressure to press this light body to capture the detail, I will then puncture a hole over the particular preparation that I'm working on. Because the whole idea is, in the end, you are dealing with a material that has memory of the dimensional accuracy. And so if you choose to use this technique, you must tell your laboratory that you are sending in an impression that you've taken under two-step. because once this impression has been taken and the material sort of recoil with its memory, your preparation, the dye that they create is marginally, by only a very small amount, a bit smaller.
Yeah.
So they will actually have to use a bit more dye spacer to counteract this kind of discrepancy. To minimize that kind of situation that is why we are puncturing this hole over the preparation that you're taking. It's a little bit like just drilling a hole for your implant impression. Same kind of concept. Yeah. Now, with that being done and you clear up all the debris that you have cut, you now squirt the light body. And I would actually, instead of just squirting into the area of interest, I will squirt full arch, because that takes care of any issues of as you reseat. And you'll also capture all those nice occlusal details also without bubbles into the fissures. Yeah. It's quite beautiful. It is. And then and predictably, you will be able to capture a very high definition of this sulcus space that we've always talked about. And I believe, Ben, you may have a few more coverage on this hydrophilicity and later on a video to illustrate what I've just spoken about.
Yeah, would you guys use a triple tray? This is a question from the audience for a single unit. Any thoughts on that?
I used to use triple tray for bite to get patient to bite into to make provisional crowns.
Right.
But I visit the lab quite a bit, and then I've used triple tray before when I was a general dentist. But the main thing I had see at the time was basically the triple tray, the articulation. They just took so much give in it.
Right.
So often your crown will come back without contact and with So as a specialist. All our crowns need to be in contact, so yeah.
So what Johnson's trying to say is that he's very particular about occlusion.
Yes.
And with articulation using a triple tray, it's not good enough for him. That's what he's trying to say, very politely. Would you guys use a custom tray for a multi-unit case?
So it depends on, like if I will be doing a two-step, then basically I'm customizing my very own tray already. If it is for a single step, then there are times where I would use,
But you do have to watch out for when there's quite a bit of undercut, because the
So
special
rigid.
tray is so rigid.
So hard to take out.
So hard to take out,
Yeah, absolutely.
Yeah.
So moving on to a little bit of material science, the concept of hydrophilicity. This is a topic that I'm sure, when we were all undergrads sitting through biomaterial lectures, this is something that our professors have told us that it's very, very important to choose an impression material that's hydrophilic, because the more hydrophilic material is, the more it likes water. Our mouth is a wet environment, and therefore it would work simply better. So now these hydrophilicity is measured. There's something like 6 different ways to measure it, but in dentistry, often this is the measurement, which is the water droplet test. So a deionized water droplet is dropped onto the material that you want to test, and then over time, you wait until the water drop slump, and then you use a special software. You calculate the angle of contact between the water droplet to the material that you want to test. And if it's an acute angle, then that material is deemed hydrophilic. And if it's an obtuse angle greater than 90 degrees, then that material is deemed hydrophobic. So basically anything under the 90 is technically hydrophilic, even 89.9999 degrees. So what that means is that a lot of impression materials that we use today, as you can see in this bar graph here with the red dotted line, the red dotted line is 90 degrees. So anything under the line is deemed hydrophilic, anything above it is hydrophobic. So although the study has been done quite some time ago, but as you can see, a lot of the material that we still use today, imprint, Phineas, honeycomb, aquasil, etc. So all of a lot of these materials are in that sort of 70 degree range, which in a way is quite hydrophobic. So now what does that mean to us really at the end of the day? Is hydrophilicity really that important? I used to think so, but until I watched or saw this particular video that I want to share with you guys. So just a little bit of background on this video. So this video was shared to me by Dr. Felix Worley, who is a scientist that works for DMG in Hamburg, Germany. So this guy is not a dentist, he is the head material scientist. So his job is to tweak chemistry and compounds and is to make impression material better. So this man has a very, very good understanding of impression materials, much better than I do. But the video that he's showing me here is him attempting to take an impression while underwater. So he's using a two-step technique. So he has already made the heavy body tray, like that's what Dr. Agnes was talking about earlier already, and now he's just injecting this stuff underwater. As you can see, he's just making a total meal out of it. Or it shows that this step is not necessary. And by the way, he is just a material scientist and he's not a dentist. So he's never taken an impression in a patient's mouth in his entire life. And now he's injecting this light body material into the tray, or the heavy body. And then he's going to go squish while underwater. And then after appropriate setting time, he's going to remove it. If you have ever removed an impression from a plastic model, you will know that it's quite hard to remove because the model is so rigid. So what you guys can see is that Felix has carried out a full arch impression. He's done a perfect impression while underwater. When I first saw it, of course, my jaw just dropped. The first thing was, what on earth is that material? Where can I buy some? And secondly, what's so unique about this material that you can do that? Because I'm a trained dentist and I can't even do that. And why is it that you're able to do this while underwater? So Felix's answer to me was, this particular property that the impression material has it's not unique to their brand. Of course, he's trying to sell his material to me, but he says, I would love to say this is unique, but unfortunately, it's not unique to our brand. A lot of other PBS material out there exhibits this property called thixotropy, which I had to practice a number of times before I can say it right. Now, this, as you can see on screen, we've got two concepts here, viscosity and thixotropy. Viscosity, we all know, it's something that's runny or thick. Thixotropy, by definition, is the ability for a material to flow while under shear force. So, for example, if you were to apply air at an angle when the material flows, that's thixotropy. And the layman example that Felix gave me was the ink for a ballpoint pen. Where normally the ink doesn't just flow out, but when you write with a pen, when the ball starts to roll, that's when this ink starts to flow out. So hence thixotropy. I used to use an impression material that actually is very runny, so low viscosity, like that little green puddle that you see. Because what I like is that when you inject that light body material, it just flows all the way into the sulcus space.
It also drips everywhere.
It does. It does. So that's why one of the questions asked earlier is that what sometimes form drags. So for me, it was especially when you lie the patient supine or fully supine, it's the distal palatal usually. Where the material is slumping down because the gravity takes the better hold of it, and that's where you get a drag mark like you see in this picture here. And when I was introduced to honeygum, this yellow color material by DMG, you can see the difference when you use air, where you can thin the material out really well, and yet there's all the little tags, which is where the air didn't hit it. So in other words, the material doesn't slump very well, or at all, I should say. So when I first used this material, I was very concerned. I'm like, what kind of light body is this? That doesn't even flow. But that's where air application comes in. You've got to blow air to get it into the impression material, and then it doesn't slump. And whether you're using a one-step technique or two-step technique, this is the one-step technique. Hence, that's why air application for this particular material is so important, so that I can now visually see the light body all the way inside the sulcus.
And I think that clarifies a point in terms of why has there been so many who advocate you have to blow air to the light body, and some who advocate, no, I don't blow air. Like, you know, even though they are both using PVS and they're both using light body, is the difference in the thixotropy.
That's right.
It's in the,
so you have to understand the material that you work with. It's not just the technique alone, isn't it? So here's a clinical case which, you know, I struggled. It's again one of those deep subgingival cases, and I just could not control the bleeding. So I've attempted to use the one-step technique using this material. As you can see, we do not have a continuous tag all the way around. There's bubbles, there's drags, and it's just not a clinically acceptable impression. And that's the impression on the left. And on the same day, I've used the two-step technique, and you can see that things just looks so much better. Now I'm able to use that pressure to force the light body literally down into the sulcus space. Despite that there is bleeding, we're able to capture a much better impression. Moving on to the next topic, and once again, guys, thanks so much for sending in so many questions, which is really great. So do keep them coming, and we can stay on for a little bit longer after the our anticipated hour and a half to answer some more questions. The next phase or the stage here is provisional. You know, now that we have taken a good impression, we can't just send the patient home like that. They have to walk home with something. Yeah. Yeah, so this is me just trying the putty key. Agnes, any particular tips that you have to make your putty better and to cut down the clinical chairside time? Because a lot of people says, oh, you know, it's just a provisional. I don't want to spend so much time on it. So any time-saving tips will be appreciated.
Well, I tend to think that when we use the the temporary material, it's a type of resin. So similar to the way I like to handle my composite resin is the least finishing, the better. So I want to create a putty that is of high detail. So similar to the putty you see here, it could be relined either by a light body PVS or fit checker to really capture especially the interproximal details. Subsequent to that, when you are practicing or when you're actually seating this putty, I apply very firm pressure, not on the occlusal because you don't want to thin the occlusal areas of your provisional crown out, and not buccal palatal because, again, you don't want to thin those marginal areas out either because they're the most vulnerable. You don't want to keep going back to realign them. Where I would apply the firm pressure is often at the gingival area. So I do make my putty key at least maybe about 4 to 5 millimeter beyond my gingival margin. And in cases where I have actually planned and prepared multiple anterior cases wise, where I already have a model, a stone model of the diagnostic setup, I would actually take the back of the crown and do a minor trench just beyond the gingival margin so that in my putty it has a positive pressure to apply in those areas. And the whole idea is that when I create this temporary for use, when I remove the putty, I actually have just a very thin edge to the excess where I could just peel away and do very minimal trimming for the contour. What about you, Johnson?
Yeah, that's an excellent tip, Agnes. I tend to find that bisacral is such a hydrophobic material, even if I dry the tooth, but if I just inject the provisional material into the putty, I often have to reline the margins.
Yeah.
So what I find helpful is I not only dry the tooth, but I also inject the bisacral material into the margin.
Yes. Onto the tooth.
Onto the tooth and into the putty as well. And then when I do that, nowadays I don't have to reline my margin as much.
So it's almost like using a light body in the mouth, heavy body in the tray.
Yes,
whereas, you got, a bit of both and squish
without
together.
Without the air blow.
Yeah. No, that's a terrific tip.
Yeah.
I tend to find making temporary bridges and temporary crowns is a little bit different. There was one clinical mistake that I made once, which when you make temporaries, you always want them to lock in place because you don't want things to come out. So I think it locked in place a little bit too much. It was binding too much on the abutments. And it was a fairly long bridgeable cell, so obviously being a resin material, there's definitely preliminarization, shrinkage. So I think it was the tension in the temporary bridge and the shrinking of the pure material together. I think it pulled the abutments closer together than what the impression was. Yes, temporary orthodontist. So when the bridge came back, it fits the model perfectly, but it was just not seating down. So I learned from that, and I realized never make your temporary bridge so tight, which is very different from a temporary crown. So the temporary bridges I think has to be a lot more passive. So here on the video you can see that my margin wasn't as good as Johnson's, so I did have to use some light flowable composite to add to it, and then you can cure. And I guess that's one of the beauty of using a bis acro is that you can add and trim and however you like. In terms of polishing the temporary bridge, any particular tips on that? Because you're a big fan of using discs, aren't you, Johnson?
Yeah. I find this is very good in controlling the incisal edges and also the in-bridge space. But also, I find a fine tip diamond is very good in clearing the gingival interproximal space for cleaning.
Definitely, yeah. Any particular temporary cements that you guys like to use?
I like what you have at the practice with the Provical because it's very clean on removal, and it doesn't tend to stay on the tooth.
Yeah, it's a rubber base.
Yeah. So I find that very helpful as opposed to your traditional temporary cement or temp bond, which has usinol and it tends to be a bit messy. But on that note, one of the tips that I like to do is before I cement the provisional bridge, I would smear a little bit of Vaseline on the exterior area around the margin, just so that the temporary cement can come away a little bit more easily. Yeah.
Any tips on excess cement removal? Because I always find that I'm using my Explorer and there's always another bit that comes out.
I personally like to take my time. It's not because I'm a slow operator, but no. I find that if you allow the cement to actually achieve more bodily set, then and if you have the trick here is to have beautiful provisional margins, because if you have great margins and proper seating, then the excess cement once have a bodily set, you should be able to just flick and as they remove it comes off as one piece. And you can almost see where it breaks off along the margin, and if there were to have any little specks that is left behind, you can also see it as a little jagged area on the one big piece, and you can go and look for it. But also, of course, you will go over the area with your Pixters or Superfloss, just to ensure you clean up all those excess. So here I'm, putting the temporary bridge in, taking it off, putting it in, taking it off. Again, I'm trying to achieve that passivity. If it just binds too much, then I'll have to take out some mouths and just trim a little bit more until it's totally passive. How did you get those nice shine on your provisional, Ben?
Very painfully polishing.
I believe you use more than just the disc here, though.
Yeah, so I went through the whole series of black, red, yellow, and then finally using the diamond impregnated occlude brush.
The occlude brush.
Yeah, I found that works pretty well.
Yeah, the occlude brushes can often drive that luster, I find.
Definitely.
Yeah.
One question from the audience. Any thoughts on shrink wrapping your temporaries?
If it's single unit, sometimes I still prefer, I don't know, it's the OCD out of me. And then, but multiple unit, you do risk when you shrink wrap to move your abutment. So
Yeah.
yeah.
Yeah, the only time that I actually consider shrink wrapping is usually temporary veneers, particularly like multi-unit veneers.
Yes.
I mean, you just sometimes can't, temporary cement.
No.
Using the, say, Provical, for example, temporary veneer, so you don't really have much of a choice. So that's when I'll probably shrink wrap it. But usually for a crown or a bridge, very rarely do I think I will use that technique. Yeah. And now we are temporarily cementing the bridge in place, and we're just using a small amount of Vaseline. We're not putting any inside the bridge, guys. It's only on the outside. This is just so that it's easier to remove the excess.
And also, how do you ensure that you don't put too much temporary cement in as you do this?
I think I'm definitely guilty here of using too much temporary cement. Hey, I was doing a demonstration for the ADA. The last thing is you want is not putting enough temporary cement in there. You try to put it on, and you go, Ben, what's going on?
Ben is
and then you got to pull this whole thing off.
What not to do?
yeah. So I'm like, yeah, you know what? I'm going to err on the side of caution. I'm just going to put a little bit more. But look, usually I probably wouldn't use that much. Just enough so that you have a thin layer to cover the inside, and that's pretty much it, really.
Yeah, like what you're now doing, like spreading like butter to get rid of the excess before seating. Yeah. So it's still okay. Sometimes you put in a bit much to recognize that before you seat and clean it out, like you had done.
Yeah.
I think that was what you're trying to show.
Yeah.
Yeah.
Another tip that I like to use is that once after you finish your cleaning of your temporary cement, particularly if, actually it doesn't matter whether it's single or multi-units, I really like using the pixlers. I always find that when you use the pixler, there's still a little bit more rubbish that comes out.
Yeah, that's a great tip I learned from you. Yeah, using the pixlers. Yeah.
Okay, well, we'll move on. Johnson, you do a lot of aesthetic cases. How important is a well-made provisional for you?
Yep. It's very important because, I mean, although we can do digital mock-up, and then we can do direct mock-up with a composite or through wax up with a bisacral material, but it's often when the patient have tried that provisional in the mouth, then they can foresee whether they like it or not, even though they had several try-ins beforehand. And for this patient, I mean, sometimes patient's expectation can change throughout the treatment.
Yes.
So this patient suffered trauma when she was very young, and then her main complaint was the discolored crowns that she has. So we did a bit of a composite mock-up on tooth 1-1 to make it symmetrical to the other central. She liked it. We do a bit of a composite mock-up by building the profile of our tooth 1-2 to match the contralateral. She didn't like that as much. But however, I mean, even though the 2-2 was asymmetrical to 1-2, she liked it because she's got used to it. So her main concern was the color. So I did a diagnostic wax up to build up tooth 1-1, but leaving tooth 2-1 and 2-2, the crowns form as they are. And from there, on the same day, different day to my diagnostic wax up, but I built up the composite on tooth 1-1 and also removed the crowns on 2-1 and 2-2. She was happy with the appearance when she left.
Yeah, despite the asymmetry of the laterals.
Yeah, despite the asymmetry. But then she had a look over the next 2 days, and then she thought, well, hang on, they do look asymmetrical now. And she gave me a call and they said, can we change it? Well, I said, well, that's great. That's communication. And then I pass on the information to my ceramist. And then we met the final to make it symmetrical in this case. So what I have learned is, even though I go through digital mock-up, direct mock-up with a wax up trying, And then a provisional, detailed provisional, I still did the patient note. Sure, you change your mind, please let us know within that week.
Yeah, definitely.
Yeah, but after that first week, once, we give the ceramics go ahead, then we can't change it anymore.
Yeah.
Or we say, give us a call and then we can hold the job for you.
Definitely. Yeah. No, that's an excellent case. There's a couple of questions on the name of the temporary cement that we use. It's by Vocal. The brand, the material is called Provisionalisation. By Vocal. It's a really good material because it's eugenol free and also it contains calcium hydroxide. So it helps with the formation of tertiary dentition. So in other words, it tends to decrease some of the sensitivity of your prep, and also because it's a rubber-based compound. So it's much more forgiving. When you use like temp bond, when it starts to set, it becomes reasonably brittle. Whereas this material, there's still some give. There was once I remember I was working and I was flossing and then oops, I flossed it off. Not completely off, but I can see it as sort of dislodging. But the material was still reasonably flowy at the time. I don't recall. I just glue it in and I just keep my fingers crossed, and it worked quite well. So. I'm not saying that's what you should do always. Just saying that sometimes you can get away with things.
Oh, speaking of which, I remember going through this checking occlusion with your temporary material. Yeah. Do we all agree that we check before we cement?
Yeah. Always check your temporaries before you cement it on, so that so you avoid the problem of you cement it on and then you check the occlusion, and then when the patient grinds, and then your temp bond whatever comes off.
Yeah, it affects the setting of the.
I think I like it because 90% of the cement will stay on the temporary crown.
Yeah.
And the other one is, with the temp bond, it's not very forgiving. If you got the timing wrong, or if you try the path of insertion and that's not the correct path of insertion, you cement it again, then the cement is sort of brittle stage, and you just have to remove everything and restart.
Yeah, absolutely.
Yeah.
All right, so now we are going to move on to the next and the final small segment, which is a little bit on bridge work. Certainly during our undergrad training, we were taught primarily to use fixed connectors for our bridges. The concept of non-rigid connector, I remember it was covered, but I certainly never done a bridge as an undergrad, and I don't know anyone that's ever done a bridge as an undergrad using non-rigid connectors. Yeah. But yet it's something that I think since in specialist practice, I see no reason why not to introduce it, and it's so easy, so straightforward. I think it should be sometimes taught as the go-to bridge design, I think, in a lot of the cases. So that's why I think I just want to quickly cover that for the audience out there. Although dental implants are something that we all do these days, it's a very common treatment modality, but not all clinical cases that you can sometimes put an implant in. There are cases sometimes you have to do a bridge for. It could be it's an old bridge that you might have to replace, or sometimes the patient is simply not suitable for that. And one of the most clinical problems we get with bridges is that the two abutments are not parallel. Like we can see here, the distal abutment is leaning forward. Now, if you were just to go ahead and prepare these two abutments for a bridge, well, certain areas you have to overcut, particularly that mesial of that sort of the mesial aspect of that molar that's leaning forward, and sometimes you even have to cut the abutment behind. So not only that's over prepping these teeth, but also you're affecting the bridge's retention and resistance. Again, orthodontic uprighting is a good option. But again, not all cases or not all patients will simply accept that. So sometimes you have to deal with non-parallel abutments. So that's where the concept of a non-rigid connector comes in, where each teeth or each abutment is prepared in its own long axis. So essentially, you've done two crown preps. Just follow their own path of insertion. It's the laboratory that makes the bridges in two sections in their own path of insertion. Typically in the non-rigid connector, it's like a lock and key. It's like a slot that's slotted into the distal aspect of the mesial abutment. And the two of them are inserted somewhat together at the same time, but in their own different path of insertion. So the concept here is stress breakers. Just like all these big bridges that we drive on, like the Sydney Harbour Bridge. Although it's one big bridge, but it's not in one huge hunk of concrete. It's in different segments of concrete. and it's divided by these stress breakers. There's different materials and designs out there. It's designed so that things work together as a one piece, but having a differential in mobility in each of the sections to allow whether it's thermal expansion or whether it's different weight distribution through different types of bridge, so to prevent things from breaking. Just like our teeth, they move independently, but yet they work together. This is a lady who has received some upper crown and bridge work quite a number of years ago, and they're now failing because of marginal leakage. She has a 4-unit bridge down in quadrant 2 from 2.4 to 2.7, I think. And she loved the bridge all these years, and she simply wanted to replace her missing teeth in quadrant 1 to replace the 15 and the 16. And because the two abutments, the 1.7 and the 1.5, they have already been crowned, there's marginal leakage, I've got to change the crowns anyway. So I thought, well, and also the patient has a previous experience with bridges. I thought this is a great opportunity to do a 4-unit bridge. So once I got rid of the two crowns, and as you can see on the next slide, that these two abutment teeth have their own unique path of insertion, which I did not need to correct. And so I simply asked the lab to construct a 4-unit bridge, but with a non-rigid connector on the distal of the mesial abutment, which is really it's the gold lock and key. So when you deliver this crown, you would insert the crown first, and then the distal piece immediately thereafter. Aesthetically speaking, when you view it from a buccal aspect, you don't see the metal, but of course, if the patient will open nice and wide, you do see a little bit of that gold island, which in this for this particular patient wasn't a problem. So the main concept here is to allow the different path of insertion, because the two teeth have different angles, so you can prepare each tooth in its own long axis and preserving their retention resistance, and also to allow for differential in movement. When do you guys tend to use non-rigid connectors?
I think your case just now illustrates really well. So if you actually go back to the slide, so for example here you've got a 4-unit bridge. By placing a non-rigid connector, ultimately will change the mechanics to become one single crown and effectively like a 3-unit bridge behind it. So one of the aspect of, we know already if they have different path of insertion, we can use it. Differential mobility, we can use it. But the thoughtfulness in clinical application is, for example, in this case, if the patient has mandibular dentate occlusion against this bridge, if it was a fixed connector, I would probably try all I can, biscuit bag trying, whatever it takes, to try and develop group function occlusion on this bridge, because you certainly do not want it to have any challenges of that resistance form.
Absolutely.
If it was against a distal extension settle where you don't design heavy occlusion towards the back and you're aiming towards more, closer to the abutment, which in this case would only be heavily biting onto the premolar area. If you leave that as a rigid bridge, then again, you would risk having the marginal leakage at the distal of that 7. So by doing a non-rigid bridge design here, what we can nicely and easily develop for our laboratory technician and less demanding in that thought in terms of occlusal scheme is you can more easily design only the 4 to be in group function with the canine. And because it is a single unit and have good retention resistance form, it can handle that together with the canine. And then you can more easily, because of that development, more easily to keep the 5, 6, 7 free from any excursive movement.
Yeah.
And so there are many ways in terms of why you would then put that into a clinical application. I think that case really illustrates it well. Yeah.
Johnson, when would you want to exercise a non-rigid connector?
For me, I mean, both of you mentioned would be when there's a differential mobility where at the basically at the root level or at the coronal level, because what we often see the complication with differential mobility is we have marginal leakage or debonding of the abutment. So at the root level, it can be a shorter root or basically a premolar versus a molar, or we have reduced periodontal support, or if we have pre-existing crowns and that tooth doesn't have as an ideal retention and resistance form. I find it helpful.
Yeah.
Yeah.
Yeah, no, absolutely. Guys, thanks so much for sending in all your questions. There is a lot of questions that we haven't gone through, but I don't have any problems with staying behind a little bit longer to answer any of these questions. But I think what we do is that because it is coming to time, it is already past an hour and a half, and I know there are audience that do need to go and leave us. So I think what we'll do is that we'll just conclude with some take-home messages, and then we stay on and just to answer just a few more questions. So for the ones that's interested, you can certainly stay logged on and continue. So before we leave some of our audience tonight, guys, any take-home messages?
I think in terms of reducing stress, when it comes to everything, I relate everything to my motherhood. So when I start to yell and scream at my children, most of the time it's actually because lack of time and lack of my own ability to contain and troubleshoot. So, and that's actually every aspect of life. Yeah. If we allow ourselves enough time to troubleshoot, enough time to actually plan and do things and not have that stress element, then we are all very capable people, to have come this far to our career. We actually, if you give yourself that time, you're all able to do many of the troubleshoot yourself and do excellent work without those stresses that we talk about. And so I think my take-home message is time.
Yeah.
Yes.
Johnson?
Yeah. Yeah, I mean, in a specialist practice, we often get refer challenging cases. I find it's important to ensure meticulous planning, diagnosis, trying, detailed provisionals, don't cut any corners, ensure patients happy before making the final anterior prosthesis.
Yeah, taking one step at a time.
At a time. How about you, Ben?
Look, I think crown and bridgework can be stressful. It doesn't matter what you do. I think we all have clinical problems. There's so many steps involved, there's so many materials you got to use, so many other people you got to rely on sometimes to make it work. So it's invariably, we are human. So it is we all make mistakes, we all have problems. But at the end of the day, I think it's important not to beat yourself up too hard.
And I think actually it's really important to highlight I personally find a lot of the times the high aesthetic challenge cases, if you can convince that patient that it takes time to develop aesthetics, it takes time for them to arrive to what they want in terms of aesthetics.
Right.
And when your patient gives you the time, that is where you've scored gold. It's not when you just create the time for yourself, but you're able to communicate.
It sounds like you've lowered their expectation.
No, I think it's in the communications. When they realize that you are actually giving them time, they really value that.
Right. No, that's words of wisdom. So, so like I was saying, because the fact that it can be quite stressful and everyone makes problems. So don't feel too bad. If something happened, we all learn from our mistakes. We are here to help at the end of the day. We are constantly receiving, text messages, Facebook and messages, emails and phone calls on a variety of clinical problems. So don't be shy. Don't hesitate to contact us if you have any problems. So on that note, I want to thank everyone for joining us this evening. This session will be is being recorded, and it will be made available to watch on demand on our website at a little bit later. So for the ones that's leaving us for this evening, thank you so much for tuning in. Thank you so much for your support in us. We really appreciate that, and we look forward to seeing you guys next time. And good night.